Hello, everyone, and welcome back to our next episode here on the podcast, our association with NACB and Sequence, CBD and CannabisInfo.com, and hosted by yours truly, Dr. Mary Clifton. And of course, with great thanks and much appreciation to all of our viewers. It would be, without our viewers, we really wouldn't have a podcast to share. I'm featuring today the epic Dr. Uma, who's, let me start that again because I'm worried about your last name. I never say your last name. It's Dhanabalan?
No, it's Dhanbalan. That's right.
Dhanabalan. Okay.
Yeah.
All right. I'll get that right. Dhanabalan. Okay. All right. Let's start again. Hello, everyone, and welcome back to the next episode of our podcast, produced in collaboration with NACB, CBD and CannabisInfo.com, Sequence, and hosted by yours truly, Dr. Mary Clifton. Today, we are featuring the epic Dr. Uma Dhanabalan, as she's going to be talking to us about all things cannabis, particularly addiction, which is the subject that we're featuring for this month. And we're just going to go ahead and get started. Dr. Uma, we've known each other for such a long time. We were talking about how we worked together for the Wendy Love show in the past. And so this is going to be a really fun interview to get caught up and then to hear how things have been going for you.
Sounds wonderful. Thank you so much, Dr. Mary, and having me here today and the opportunity to talk about a topic that pretty much impacts everybody in some way, shape, or form. Either they know somebody or have experienced it themselves, and it definitely impacts everybody in the society as well.
Oh, yeah, even if you don't know somebody who's dealing with it, and I think we'd be hard pressed to find somebody who doesn't know somebody, but just the economic consequences and the experiences in so many towns and cities across the country with opioid dependence and addiction, and the way that it's ravaged our communities is a very powerful topic.
Absolutely.
Can you tell us, do you have any patient experiences that you can share, any experiences with the people that you've worked with, Dr. Rama?
Absolutely. So, when we talk about addiction, we talk about what is addiction and to define it, and also that it is an illness and that it can impact anybody at any point in one's life. And there are some predispositions that we see as far as genetic predispositions. We talk about, nature and nurture. And so these are all the factors that I really think about as my foundation is as a family practitioner. And I'm also an occupational environmental medicine physician. So when I exposed to addiction, it's been in multiple facets. It's been as patients or in the work environment. And we've had where I'm also a medical review officer. So as a medical review officer, there's drug testing that's involved. And sometimes, identification of addiction comes in different ways. It could have been identified where somebody's coming into work and an accident happens and the drug testing occurs, and we find out there's a drug that's positive that should not have been positive. And when we start to understand that there's something more than just the accident that happened, that might have been a venue. As primary care, I've seen it where patients were just prescribed a medication for a condition, an accident, an injury. And what was originally just as a treatment became something that they had to be on it for an extended period of time. And before they even realized that they had built up a tolerance, and it also becomes part of a habit. And that's a whole nother conversation as far as how habits are different than addiction, and how we have to understand what are the components that are involved in it. So what we've seen with addiction is that we've seen young patients, we have teenagers that are addicted, to seniors that are addicted. And addiction is anything that I look at is that where it impacts one's quality of life, and it interacts not only themselves, but also the people that they care about the most. and not able to function in a job or to able to sustain their livelihood. And what we've seen with addiction is addiction to alcohol, addiction to nicotine, addiction to opioids, sex, gambling, internet, and the list goes on as what people can get addicted to. So we have to understand that people have to understand what is addiction and what people can get addicted to. So two different things to really understand before we address it to patients.
It's so true. There are so many different situations that people find themselves entering a situation of addiction and dependence. I just was chatting with the bartender at the steakhouse that I like to go eat at. I love to sit at the bar and watch the bartender make drinks and eat and eat. I don't know. Often I don't even eat a steak. I just eat a salad and a potato. But I love that action at the bar. That's my favorite seat in a restaurant. And then I chatted with her about cannabis and addiction, and she said both her and her boyfriend got into a situation after a motor vehicle accident, and they got pretty beat up during the motor vehicle accident and ended up, both of them on narcotics. For the boyfriend, not as big of a deal. Maybe his injuries were less, or maybe it just was, the genetic predisposition that you spoke of, and he, didn't have as much trouble, but she got into quite a bit of problems with addiction and dependence, and getting off of that really has been a heck of a struggle for her.
And I'm sure it's very hard for not even that person. It's when you have somebody that has an addiction illness watching them. And, when we talk about alcohol addiction, we talk about enablers and how what's their role. And then now with alcoholism, we talk about, the individual and then the family members, alcoholics, the family members that have to be treated as well. So with addiction, that's the same way that I feel, alcohol has been well studied, and we've seen the impact of this, not just locally, but globally, where I'm originally from India. And I remember going back to school in 1979 to India. And India at that time, prohibition was in effect. And there was 3 ways that people could get alcohol. And one was that you had a green card, or you had a foreign passport, or that you had a letter from a doctor that you needed alcohol to survive. And when you think about how things have evolved, with how alcohol has been looked at, and, at that time, we didn't even really understand the impact of fetal alcohol syndrome, women consuming alcohol during pregnancy. And when we look at how things have evolved over time, even, and what I understand is that now we understand addiction to be an illness. It's not something that people just choose to do. And why somebody could use the same thing and it doesn't impact them, somebody else uses it and they can get addicted to it. And what we've seen with our patients is how I'm able to use cannabis and why I call it an exit drug for my patients, because many of them come with even pharmaceutical medications that they've been taking for their medical conditions. And you realize, well, you've been on this medication. Has there been a plan to get you off of it, or maybe even reduce it? Oh no, this is not a problem. I'm taking it and it's for my pain. And you realize that, well, they've been taking it maybe as a habit and something that they really build up a tolerance to. And I've had patients tell me, I'm not an addict, or they'll come back and say, I didn't realize that I was addicted to it.
Yeah. It's how I'm smiling because because I'm waiting for all of these Dr. Uma bombs to drop, where you're always dropping knowledge and, cannabis as an exit drug. You always have these great lines, but it's so true. So much of all of the crazy old research that suggested that people that started with cannabis would end up being, skid row bums with needles hanging out of their arms, actually maybe the other way around, where people who who are dealing with lots of issues with opioid dependence could find themselves being able to reverse that dependence or step out of it with using cannabinoids.
Absolutely. And when you look at the history, as I said, when I started to learn about this really as medicine was in 2010, and understanding that we had an endocannabinoid system, I had learned about cannabis, all the negative aspects and how we were going to penalize people that tested positive for this chemical known as THC. And today, what I'm telling people is that, this chemical and this plant was used and it was listed as the treatment for opioid addiction. It was the treatment for alcoholism. And many clinicians don't even realize that this plant was part of our pharmacopoeia and that it was listed in the pharmacopoeia from 1850 to 1942. And lo and behold, one of the indications of use was opioid addiction, alcoholism, not the cause of, or not the gateway drug as we've labeled it. And why I use this word of exit. And I say that if anything, cannabis is an entrance to a better quality of life, and it's an exit from pharmaceuticals, narcotics, alcohol, nicotine. And we're also even using it for people with food addiction, right? Or food aversion, because, addiction can go with where you're not using it or overuse. And when we look at people with anorexia or obesity, I think of it as another form of addiction as well, where it's overconsumption or not enough consumption of necessary calories. We are so addicted into our body image of how that is that they lose the importance of nourishment to one's body. So, when we understand how addiction can be applied to different facets, it's really what people have to understand is what I always say, when it comes to cannabis, please open your hearts. You don't need to use this medicine, but you know somebody that can benefit from it. Let's open our minds because we all have an endocannabinoid system. And yes, it does have the word cannabis in that system known as cannabinoid system. So understanding that, yes, that there's cannabinoids that our own body produces, that we can get it from plants. And of course, man will synthetically make this as well. So we've got synthetic cannabinoids, we've got phytocannabinoids and endocannabinoids, which all work in our body system. And I really believe addiction is also a depletion of one's endocannabinoid system. And replenishing it with cannabinoids could possibly be the treatment.
I agree with you. I think there are these endocannabinoid deficiency syndromes, addiction being potentially one of them, and also disordered eating, either in the range of not eating enough or eating too much. Although those treatment patterns are, we just don't have anything that's particularly successful. But I think that people are always surprised to find out that somebody who's been using cannabinoids over their lifetime maintains a normal, like high school range body weight, like a healthy BMI, at a much higher percentage than people who don't use cannabinoid formulations over their lifetime. You always hear the munchies and everybody thinks they're going to get really heavy. But so many of these conditions strike me as endocannabinoid deficiency syndromes, and particularly some of the musculoskeletal pain syndromes, where, studies show 100% of people with fibromyalgia in the study stopping their opioids in favor of cannabinoids when they get started on a product like that.
Absolutely.
Has that been your experience in your practice?
Absolutely. I remember when fibromyalgia was kind of the diagnosis where people were just, they didn't know what to call these people, people didn't believe that there was a thing called fibromyalgia. They didn't believe people could have these chronic fatigue syndromes, even things like Lyme's disease and some of these diseases that are real. And so many people don't believe in it. And I do believe that this is part of the understanding that, people don't understand that we have an endocannabinoid system, never mind that there's a deficiency in it. So this is where I really feel that our patients are demanding almost of our healthcare providers to understand about this. And I'm almost surprised that the AMA has not brought about more mandatory regulations in the healthcare system. Just as much as they put drugs in a Schedule 1, why have they not mandated healthcare providers to understand about a system? And especially when we've got over 30 some odd states that have a medical marijuana program.
Doesn't it strike you as just amazing that we aren't educating our upcoming doctors about the endocannabinoid system and about at least, even though the research is, albeit not what we're conditioned to think is great research, but boy, oh boy, they don't know anything.
You bring up a very good point. Let's talk about this research, because my grandmother was a shaman. She didn't read and write. She was the doctor. She looked at a person. She didn't have any double-blinded studies. She didn't have Google. She didn't have textbooks and all of these other things that we have access to. Everybody has access to. And yet they knew what to do, right? And yet we're asking for double-blinded studies. And we've got plenty of them. And that's why we have this thing called an opioid epidemic.
Yeah, no kidding, because the double-blinded studies supported
we got drugs to the market,
right?
We were part of when OxyContin came out. We were part of when the fifth vital sign for pain was established. I was a part of that. I remember 1996 being called in to a room and said, pain is the fifth vital sign. And by the way, if anybody has a pain scale on this happy face scale greater than 5, you better make sure they walk out with 10 pills known as OxyContin.
Yes, we had the same thing. I mean, it wasn't only, it wasn't only a lecture that was delivered to us. It was a lecture delivered to us by the dean of our medical school. And our dean, it said, you have got to treat pain. And if you don't treat pain, it's a medical malpractice issue. It's a bioethical issue. We have good medicines to treat pain, and you need to make sure people are treated and also given additional medicines for breakthrough. We were instructed on how to initiate the addiction, and not only instructed, but also, and I wouldn't even say strongly encouraged. It was beyond strong encouragement. It was an edict,
I remember the pads all stamped, ready to go. It was so easy, and we had them in our offices. The drug rep would come in with their samples. It was accessible. I mean, I remember those days. And what's really scaring me today is the fact when I realize that this opioid epidemic is still increasing. We are not seeing it come down. We've gone up from over 75,000 deaths to 90,000 deaths in this last year. And what I really see is, what is it going to take? Please, I beg of my colleagues, I beg of people at this point, why I speak so boldly, because cannabis has killed nobody in the
absolutely
whole world.
Nobody in the history of recorded medicine in 4,000 years.
You may try, you may want to try. I always say, when that study comes out that they're looking for that LD50, sign me up, because we know that there is no LD50 for cannabis, where we can see 50% of the people.
And a lethal dose at this dose, 50% of people will have a lethal dose. That the LD50 just doesn't exist for cannabis.
And what we realize is that if certain facts, I always want 3 facts. Everywhere I go, I want my 3 facts that I want people to know. And we've just discussed one of the facts, which is that nobody in the world has ever died from cannabis. And the second fact that we want people to know is that this medicine, cannabis, this medicine was in our pharmacopoeia and it was listed in our access for opioid addiction from 1850 to 1942. Yes, in the United States of America. Most clinicians don't know that. And then the third fact that we want people to know is they keep asking for research. Well, when the government owns the patent number 6630507, I'll repeat it again just in case, 6630507, issued on October 7, 2003, and it clearly states cannabinoids, friggin' all of them, as an antioxidant and neuroprotectant. I became very curious. I said, so you've known about this, you've known about the use, and you know about the safety. So what's the gig on why we haven't legalized it or decriminalized it?
It makes you wonder why other doctors aren't curious, you know.
I've
Dr.
always
Greenspan
asked
and I
that. Thank
talked
you for
about
bringing
this.
that up, but I think we've lost the art of medicine. We've lost a lot of things through this journey called advancement in medicine, and I'm very proud to see how much we've advanced. Yet I feel like we've lost how to talk to a patient, how to be empathetic to a patient. And I also say to everybody out there, no matter who you are, you might not be a healthcare provider, but all healthcare providers are patients.
I do feel like the art of medicine is lost in all of the prior authorizations and the, all of the billing and the insurance and the documentation that we have to do to protect against any decision we make. It's just become so overwhelming to just see your patients every day that it's hard to think creatively as a doctor anymore.
When I decided to step into this world and leave the other world was in 2012. And I don't work for any hospitals. I don't work for any universities. I don't work for any insurance companies. I don't do billing. I don't have to worry about we get a super bill for our patients, but I operate with 3 people, myself, my son, and my assistant. So we've taken away layers and I get to spend an hour with my patient. That's what I love doing. And that's what care is about. And doctors have lost their own meaning. We're seeing doctors losing their lives to suicide. We see doctors addicted. We see themselves also becoming patients. And it's because we went into this field to help people. And when we can't help them and all we're doing is writing out a script with no exit plan, and the number of pills keep increasing that you have to write, and then you've got now pills for the side effects of the conditions, there's something wrong with this picture. And I can boldly say, as I see my patients, I'm like, okay, how many less pills are we on? How much less alcohol, or how much, no more tobacco, and you've lost weight or you've gained weight, and I'm out doing things in a better quality of life.
Isn't that fascinating and just marvelous as a doctor to have that experience? I felt the same way in private practice, that I just kept I felt a bit like a vending machine for the pharmaceutical industry. I just kept writing another script, and then people would come back the next year 5 pounds heavier. Maybe they popped a heart attack or a cancer, and we'd do their next exam and go over their labs and give them their scripts, and either see them back every 3 months or see them, and the whole business model is built on that, right? You see your diabetics and cholesterol and hypertensives and antidepressant patients every 3 months, get the laboratories, review the laboratories at a second visit. So you're seeing them 8 times a year, right? And then you see them for their annual, and then they have like their UTIs or their colds. And so you get about 12 visits a year per patient. And that's the model.
It's interesting you say that, because now what's happened is my patients, they know I'm a family doctor, so they kind of use me as their doctor. And they're really eliminating their visits to their doctors. They're eliminating those ER visits, those emergency visits, their number of their episodes of their migraines, their episodes of their headaches, their episodes of other chronic complications that they had, like you said, secondary to their medications.
Yeah, I mean, and that just never happened. You know, that wasn't really ever in the plan when you're doing primary care, when you were running that treadmill. The plan was to just maintain the medications and control it rather than ever actually treat somebody to the point that you could reduce medications. It is truly a pleasure to talk to people with an eye toward taking them off of their medicines, you know, rather than just keeping them on the program.
When you're talking about that, I used to say the party pack of five, you know, the party pack of five, like which party pack is not gonna, which patient is not gonna have the party pack of five, and it would be blood pressure, diabetes, something for cholesterol, something for reflux, something for anxiety or depression. And then that didn't even include their PRN meds or what they got over the counter or what they borrowed. You know, these were meds that we were prescribing, like you said. And we didn't even need to do it anymore once electronic medical records came. It was like, yes, the script and it's refilled for how many ever times, right? And the pharmacy is calling up the patients to come pick up their pills. And, you know, before, at least I felt like they went to one doctor and somebody was able to manage them. Now there's so many different doctors, and many doctors don't even check the prescription monitoring program to see what other pills that they're on. And, you know, this is where I feel that the good old fashioned family doctor philosophy has to return. You know, this have a family, take care of 100 families. We've talked about this, you know, if one doctor was responsible for 100 families, how would that look like?
Wow. Yeah. That would be a really powerful move, like more of a concierge medicine practice, but not just for people who are wealthy. You know, for everyone, somebody who can slow down and actually look at them. You know, with the changes in reimbursement, family doctors just don't really have that time anymore. Uma, I didn't realize that you had been back and forth to India for portions of your training. Can you talk about that and what that experience is like?
Yeah, so after I finished high school, I was 16 years old, and my parents said, you know, you want to be a doctor, and, you know, we've got to get you married at some point. So, you know, 4 years college, 4 years medical school and residency, you're going to be too old, so we're going to ship you off to India. And I went off to South India. I was born in North India. I had never lived in the South. And I went back to South India in 1979 and started med school there. And it was one of the first programs that was created. The chief minister there created 5 seats for Indian origin people that were living outside the country. And I was one of the first people there. But fortunately or unfortunately, the first year I was there, I got hepatitis from the water. And
Oh.
the second year I was there, I had malaria. So my parents said, did we send you to be the doctor or the patient? So I ended up coming back to the United States, and then I did my undergraduate at Rutgers, and then I went to medical school. And prior to that, I had been doing research from tissue culture to animal research to from infertility to oncology to diabetes to hypertension. I have been doing all sorts of research, double-blinded studies, you know, drug trials, all different types of things here. And I really thought I could be able to manage in India because I was Indian, you know, but my body said otherwise. And I ended up coming back and I went through everything here. But after I finished my medical school, and even when I was in my medical school, I did my rotations, at least one rotation throughout my years in India. And then I used to go back and forth to India every year. And I spent 6 weeks in India, and I used to do pro bono work. And we have our home in Madras, and we used to do physicals. My brother has a company there, And we used to do the physicals for the employees. We used to do preventative health.
Oh,
I
that's
set up
wonderful.
garbage cans in the villages there. We talked about 5 numbers, and that's where part of when I created Global Health and Hygiene Solutions in 2006, my mission was and has been always since to promote wellness and prevent illness. So my mission has always been about education and how to do screenings. And primary screening is education. Secondary screening is actually looking at things. So we started to look at 5 things that we wanted to concentrate on, and we concentrated on measuring people's blood pressure, their height and weight, calculating their BMI. Then we would measure their waist and hip ratios. And these were simple things that we could do where we didn't have to do anything invasive. And
Yeah.
we found out about hypertension. We found out about metabolic syndrome. We found out about obesity. And then we graduated, and then we started doing blood tests, and then we started looking at their glucose or their A1C, and then looking at hyperlipidemia. And then
Wow.
we started to do exercise programs. We instilled nutrition programs. We changed up the foods. So I've been around the block doing many different things in my life all over.
So
And
you
so
really got your start in like wellness and lifestyle, just like me. Isn't that neat?
absolutely. And I think, Ben, like I said, my grandmother was the doctor in the village, and I still remember her. She would go out and look at people, and she would know and go out and pick the herbs and rub it on them, make up a concoction, help women get pregnant, babies, colicky babies, people with seizures, people with so many different ailments. And so that's in me. And I feel like I'm very blessed and grateful to have those roots in me. And,
That's just a
I,
very powerful story about going back and working in India. When did you know you wanted to be a doctor? I mean, I do think that for me, it was my mother also who was like, if you're going to be in medicine, you should try to be a doctor and be able to be, I think she could tell that I was bossy and in charge right from the beginning. And I didn't really, I'm not super good at taking other people's advice. I'm much better at dishing it out. So I think it was the right direction for me to go for my personality for sure.
it's interesting because they said to me when I was 3 years old, like somebody had a stethoscope when I saw it, and I would wear it around my neck and say, I'm going to be a doctor. And I had a habit of, being in Bombay, we would see all sorts of people, and I would bring the dirtiest kid home from the streets and bring them home and clean them up and feed them and dress them and send them out to the families. And I'm still kind of doing that, I'm still trying to clean up people and trying to still change, the world and how I do believe we can change things. And I do believe that people need opportunities. And I do believe that not everybody has everything. So we should be there to offer love and kindness. And it's also about being able to receive it. And so, and I'm very fortunate with our patients that it's a two-way street, we are able to take care of our patients. And I use 3 words: educate, embrace, and empower. And
Educate, embrace, and
and
empower.
empower. And that's a two-way street because I educate my patients. I take a lot of time and educate my patients. And I literally physically like to embrace them too, but I look at certifying them as a form of embracing them and making them legal. Because once they get that piece of paper, they can literally say, I am a legal medical marijuana patient. And they can have some affirmation, even if they've been self-medicating, that they are a legal patient. And the empowerment is that they come in with me. And by the time they get to me, they've been literally destroyed in many ways, orifices created that did not need it, traumas, surgeries, things that and so these were determined individuals by the time they come to me, and they understand that I'm not a mill, and I'm here to set goals and work with them. And the day I see them, I say our journey begins. So we empower them as well, because as they go through this, there's a starting point, there's a middle, and there's that we're going to keep working on things. And what I
And wouldn't
realized is,
everybody just love to have that, our journey begins, having somebody who's truly in your corner as your medical support team, because you just finding somebody that you can trust and rely on is so difficult. And that's such a wonderful, powerful statement you're saying to your patients, Dr. Uma.
it is because it begins my journey with them too, because I'm very blunt with my patients, and I tell them, like, look, I don't want to waste your time and you don't want to waste my time. So we're here dedicated to this, and we check in. And, that's what it's about. It's a relationship, and it's supposed to be a doctor-patient relationship. And what I feel is that we've lost that opportunity when doctors don't want to learn about things. If a doctor says to you, you're a bad person for using cannabis, or doesn't ask you, why are you using it? What do you get out of it? How does it help you? What are they doing for you?
Yeah.
And I'll ask my patients, is your doctor aware of your use of cannabis? And sometimes my patients will literally cringe in their chair. They're like, are you going to call up my doctor? And I'm like, no.
Is this going to show up on my Epic? Yeah.
Whatever. And I'm like, no, my records are here. Nobody gets my records. It's our records. I don't share it even with the patients unless they need it for some reason. But otherwise, because cannabis is still federally illegal. I mean, that's the bottom line. It's still in Schedule 1.
We need to make sure we protect our patients when we're working with this. Yeah, whenever they want me to write a letter for them, I'm always like, oh gosh, are you sure that you want me to do that for you?
And, in the other ways that we want them to be empowered by getting that piece of paper. So I encourage patients, do get a medical card, because that is a validation. And God forbid you were involved in some type of an accident, they're not going to hold this, that, because people don't understand. It's not like doing 8 gram of cocaine or something else that you're doing where you could do it and it's out of your system. My plant stays in your system because it's needed by your body. So people have to understand that cannabis will stay in your body system even if you've not used it. And this leads us into the question of impairment. People that are using cannabis are not necessarily impaired by using it, versus somebody that's using alcohol, or somebody that's even using an opioid, or even their medications for blood pressure or diabetes. I tell people, if your blood sugar drops too low, you are impaired.
Yeah, it really is a limitation to our current, studies, that we can't really identify when you've used the cannabis. You just test positive for it. So it may have been something that you used, in the past, and you're not. So trying to identify intoxication versus use is difficult with our current studies.
And there's people trying to do, these things, and I'm like, do you understand that there's an endocannabinoid system? This is not like alcohol. Alcohol and cannabis are not the same. It's not like where we could say with alcohol, one drink, this is your blood level and this is your impairment. It is not like that with cannabis. And so this is where they're trying to equate things, and without people understanding this and understanding that cannabinoid medicine is a specialty and it should be treated as that. But everybody knows that there's a thyroid gland. Everybody knows that how your lungs work. As a clinician, you know how your heart works, but it doesn't mean you're a cardiologist telling people how you should be, treating your arrhythmia. I can give them some guidelines, but I am not the specialist in cardiology, and nor are the doctors a specialist in cannabinoid medicine.
Yeah, you definitely need a specialist if you're going to be working on the cannabinoids to reduce your other medicines. And and everybody, holy moly, everybody needs some additional education. Dr. Uma, it has been so great to connect with you again today. Thank you so much for agreeing to be on this podcast. And
Absolutely.
again, thanks to the NACB, Sequence, CBD and Cannabis Info, and of course the team at Pro Cannabis Media, and our production, Danny, who's on the line with us today, making sure we stay on track. And of course, our viewing audience. It's so exciting to be able to share your work, Dr. Uma, with everyone. Thank you again.
Thank you. Please, and if they want to get in touch with me, I'm at
Yes.
Uplifting Health and Wellness, and we are located in Cambridge, Mass. I'm licensed for Massachusetts, Maine, Connecticut, Georgia, and I also write recommendations for New Hampshire and Vermont. And our youngest patient is 2 and our eldest is 98. So we take care of all ages.
Whew.
Thank you very much. What a pleasure. Thank you.
Thank you.